Welcome back to the deep dive. We know you're here not just to learn, but to really achieve mastery over some pretty dense but absolutely crucial topics in biology and pharmacology.
And today, we're tackling a big one. We're diving headfirst into the world of localized signaling, the body's internal instant messengers.
We're talking about eicosanoids, that's prostaglandins or PGs, leukotrienes, LTs, thromboxanes, TXs, and prostacyclin PGI, plus their fascinating cousin, platelet activating factor or PAF.
Exactly. These are the major lipid-derived autacoids. And honestly, if you want a deep understanding of inflammation, blood clotting, pain, even how drugs like aspirin actually work, you have to get a handle on these molecules.
Right. Autacoids meaning they're made right where they're needed, act right there, and then disappear. Super localized, super fast. So our mission today is to really unpack this whole system for you.
Yeah, we'll go beyond just definitions. We'll get into the chemistry, how they're made, the signaling pathways.
And their actions, which are incredibly widespread and, frankly, often seem contradictory. And, of course, their huge role in disease and medicine.
And the story, it starts in a kind of unexpected place. Not some high-tech lab initially, but way back in the 1930s.
From human semen, wasn't it?
That's right. Researchers found this substance in semen that did two really noticeable things.
Yeah.
It made isolated uterine muscle contract very strongly.
Okay.
And in animal tests, it caused a significant drop in blood pressure.
And that early work led to a classic naming mistake, right? A bit of a historical artifact.
Absolutely. They figured, well, it must come from the prostate gland. So they called the whole group prostaglandins.
Even though they soon found out these things are made pretty much everywhere in the body.
Precisely.
Yeah.
But the name stuck. The real explosion in understanding, though, that came much later in the 1970s.
That's when the connection to aspirin was made?
Yes. The massive breakthrough was realizing that aspirin and similar drugs, the NSAIDs we all know, actually work by inhibiting the synthesis of these prostaglandins.
That must have been a huge moment, connecting this everyday painkiller to this fundamental biological pathway. Suddenly, you could explain pain relief, fever reduction, anti-inflammatory effects.
All linked to blocking PG production. It totally changed the game.
And led to a Nobel Prize, didn't it?
It did. Bergstrom, Samuelson, and Vane shared the Nobel in Physiology or Medicine in 1982 for that discovery. It cemented PGs as, central players in physiology and pharmacology, not just some obscure substance from the 30s.
Okay, so if we want mastery, we have to start with the foundation, the chemistry, because the structure really dictates what these molecules do.
Absolutely. Eicosanoids all derive from 20 carbon polyunsaturated essential fatty acids. That prefix eicosa literally means 20.
20 carbons. That's the basic blueprint. And in humans, the main starting material, the one released from our cell membranes in the largest amounts, is arachidonic acid.
Correct. Arachidonic acid, or AA. Chemically, it's 5,7-8-14 eicosanoic acid. So a C20 fatty acid with 4 double bonds. Tetranoic means 4 double bonds.
And the complexity starts when this AA gets modified, right? Particularly for the prostaglandins and thromboxanes.
Yes, these are the ones that get cyclized, formed into a ring structure.
Let's tackle those first, the PGs and TXs. We know the name prostaglandin was a bit of a historical accident, but what's their actual defining chemical feature?
They're all derivatives of a theoretical parent structure called prostanoic acid. It's a 20-carbon structure with a characteristic 5-membered ring and 2 side chains. Prostanoic acid itself doesn't actually exist in nature, but it's the framework we use.
Got it. And the naming seems complicated, but there's a logic to it. The letters A, B, C, up to what do they signify?
Those letters refer to different substitutions or modifications on that 5-membered ring. So PGEs have a different ring structure than PGS or PGI, which is prostacyclin.
Okay, so the letter tells you about the ring. What about the numbers, the subscripts 1, 2, or 3? This seems really crucial, especially for humans.
It is crucial. It tells you the number of double bonds remaining in the side chains after the ring is formed.
And you mentioned AA has 4 double bonds to start with.
Exactly. So when the enzyme cyclooxygenase, or COX, forms that 5-membered ring from AA, it uses up or saturates 2 of the original 4 double bonds.
Ah, so you start with 4, lose 2 making the ring, and you're left with 2 double bonds in the side chains.
Precisely. That's why the 2 series, PGE2, PGF2, TGI2, and TXA2, are the most abundant and biologically important prostanoids derived from arachidonic acid in humans.
Makes sense. And the little bonds in PGF2.
That refers to the stereochemistry, the specific 3D orientation of a hydroxyl group, an OH group, attached to the ring. a small change in shape, but it can really affect how it interacts with its receptor.
Okay, so those are the ring formers derived via the COX pathway. Let's switch to the other major class, the leukotrienes, LTs. No rings here, right?
Correct. Leukotrienes are open-chain compounds. Their synthesis doesn't involve cyclization, and crucially, they retain more of the original double bonds.
And the name itself gives clues. Leuko and trine.
Yeah, it's quite descriptive. Leuko, because they were first isolated from leukocytes, white blood cells. And trine, because the final structures typically have 3 conjugated double bonds alternating with single bonds.
Structurally different. And no reduction in double bonds during synthesis via their pathway, the LOX pathway.
That's right. And the key LTs you need to know in humans are LTB4, LTC4, and LTD4. Notice the subscript 4 that reflects the 4 double bonds in the precursor, arachidonic acid. Unlike the PGs, where 2 were used for the ring.
And there's another historical link here, isn't there, with LTC4 and LTD4?
Yes, a really important one. These 2 molecules together make up what was known for decades, since 1938, in fact, as the slow-reacting substance of anaphylaxis, or SRSA.
So scientists knew about this potent substance involved in allergic reactions and asthma long before they actually figured out it was these specific leukotrienes.
Exactly. They knew what it did caused slow, sustained contraction of bronchial smooth muscle, but the chemical identity wasn't nailed down until much later. It shows how long these powerful mediators were hiding in plain sight, functionally speaking.
Okay, let's get into how these molecules are actually made. You said they aren't stored, right? They're synthesized on demand.
That's a fundamental principle. No preformed stores. They are made locally, exactly when and where they're needed. This makes the very first step, getting the raw material, the absolute key control point.
And the raw material is arachidonic acid locked away in cell membranes. So what flips the switch to release it?
That involves enzymes called hydrolases, and the main one you need to remember is phospholipase A2, or PLA2.
Phospholipase A2.
Various stimuli, often things that cause a rise in intracellular calcium levels, activate PLA2. It then snips the arachidonic acid molecule off from the membrane phospholipids, making it available for the next steps.
So PLA2 activation is the gatekeeper. No AA release, no eicosanoids. It's the rate-limiting step.
Absolutely critical. Once AA is free, it faces a fork in the road, 2 major enzymatic pathways.
Pathway 1, the cyclooxygenase COX pathway. This is the one that builds the ring structures, PGs, thromboxanes, prostacyclin.
Right. The COX enzyme takes AA, adds oxygen, and forms that 5-membered ring structure. This initially creates highly unstable intermediates, first PGG2, then PGH2. Think of PGH2 as the central hub, the universal precursor for all the COX products.
But the final product isn't PGH2. What determines whether a cell makes, say, thromboxane versus prostacyclin from that same PGH2?
Pure tissue specialization. It all depends on which downstream isomerase enzyme is present in that specific cell type. The raw material, PGH2, is the same, but the cell's unique enzymatic toolkit dictates the final signal.
Give us the classic example of that specialization.
The absolute classic is the interplay between blood platelets and the blood vessel wall. Platelets are packed with an enzyme called thromboxane synthase, so they take PGH2 and almost exclusively convert it into thromboxane A2, TXA2.
TXA2, the pro-clotting vasoconstricting signal.
Exactly. Now look at the cells right next door. The endothelial cells lining the blood vessel. They have a different key enzyme, prostacyclin synthase.
So they take the same PGH2
and turn it primarily into prostacyclin, PGI2, which is powerfully anti-clotting and vasodilating.
Wow, so it's this immediate, localized tug-of-war built into the neighboring cells. One makes the stop bleeding signal, the other makes the keep flowing signal.
Precisely. It's an incredibly elegant system for maintaining balance. Of course, some tissues, like the lung and spleen, are more like generalists. They have the enzymes to make a whole range of COX products.
This specialization naturally leads us to the different COX enzymes themselves, COX-1 and COX-2. This distinction is huge in pharmacology, especially for NSAIDs.
Absolutely fundamental. The simplest way to think about it is, COX-1 is the housekeeper. It's constitutive, meaning it's always active at a baseline level. It handles normal, essential physiological functions.
Like what sort of housekeeping?
Things like protecting the stomach lining by producing PGs that stimulate mucus and bicarbonate secretion, maintaining normal kidney function and blood flow, and crucially, producing the TXA2 needed for normal platelet aggregation for hemostasis.
Okay, so COX-1 is for the day-to-day running of the body. Then what about COX-2?
COX-2 is the responder. Normally, it's present in very tiny amounts, almost insignificant. But its production is rapidly and massively induced, ramped up in response to specific stimuli.
Like inflammation.
Exactly. Inflammatory signals like cytokines, growth factors, injury, bacterial products, these things trigger a huge increase in COX-2 production. So it's generally thought that COX-2 is responsible for producing the PGs that drive the pathological changes of inflammation, the pain, swelling, redness.
So the idea behind selective COX-2 inhibitors was to block the bad inflammatory PGs without blocking the good housekeeping TGs from COX-1, hopefully reducing side effects like stomach ulcers.
That was the rationale, yes. But, and this is crucial for real mastery, there's a nuance. COX-2 isn't purely pathological. We now know its constitutively expressed meaning, normally present and active in a few specific places.
Oh, where's that?
Important sites include the kidney, where it plays a physiological role in regulating blood flow and saltwater balance. Also in the brain, and importantly in the developing fetus, where it helps keep the ductus arteriosus open. So blocking COX-2 completely isn't without potential physiological consequences either.
Interesting. What about COX-3? Does that fit in here?
COX-3 is a bit more controversial or less well-defined in humans. It's a splice variant of COX-1, meaning it comes from the same gene, but it's processed differently. It was primarily identified in dog brain.
And its significance?
It's notably inhibited by paracetamol acetaminophen, which doesn't strongly inhibit COX-1 or COX-2. This led to speculation it might be involved in how paracetamol reduces fever, maybe acting in the brain. But its definite role and even its significant presence in humans are still debated. It's not as clear-cut as COX-1 and COX-2.
Yes. Okay, let's switch to the second major pathway for arachidonic acid. The lipoxygenase LOX pathway, the straight-chain builders. Where is this pathway most active?
You find the LOX pathway predominantly in inflammatory cells, so white blood cells like neutrophils, eosinophils, monocytes, also in the lungs and platelets. Its main job is to generate the open-chain leukotrienes, LTs.
Specifically LTB4, LTC4, LTD4 via the key enzyme.
5-lipoxygenase, or 5-LOX. That's the enzyme that initiates the process for these key leukotrienes.
And this pathway has its own special requirement, doesn't it? Something called FLAP.
Yes, absolutely essential. To make LTs via 5-LOX, you need the 5-lipoxygenase activating protein, or FLAP. Think of FLAP as a transporter or chaperone protein located in the nuclear membrane. It picks up the released arachidonic acid and physically presents it to the 5-LOX enzyme.
So no FLAP, no efficient LT synthesis, even if 5-LOX is present.
Correct. FLAP is indispensable for the 5-LOX pathway to really get going. Inhibiting FLAP is another potential therapeutic strategy, although no drugs targeting it are currently marketed.
And besides the main LTs, the LOX pathway can make other things too.
Yes, the initial products are hydroperoxy acids, HPKDs, and these can be further metabolized into other bioactive lipids like capoxylins, trioxylins, and lipoxins. Lipoxins, interestingly, often have anti-inflammatory actions, adding another layer of complexity.
It's amazing how many different signals come from this one starting molecule, AA. Are there other pathways besides COX and LOX?
There are. The cytochrome P450 enzyme system, usually known for drug metabolism, can also metabolize AA to produce various HETs and ETs, eicosanoic acids, which have roles in vascular tone and kidney function.
And even non-enzymatic routes.
Right. Oxidative stress, free radicals, can non-enzymatically attack AA to form compounds called isoprostanes. These are often used as markers of oxidative stress in the body.
And we have to mention the brain connection again, anandamide.
Yes, it's fascinating. Arachidonic acid can be enzymatically linked to ethanolamine to create an anandamide. And an anandamide is an endogenous cannabinoid. It binds to the same CB1 receptors in the brain that THC from cannabis does.
So our body makes its own cannabis-like molecule from AA.
On demand, locally, yes. It's involved in things like mood, appetite, pain perception. It really underscores how versatile AA is as a signaling precursor.
Okay, let's talk about shutting down these pathways, specifically inhibition, which is key for pharmacology. We know NSAIDs block COX. Aspirin is special, though.
Very special. Aspirin causes irreversible inhibition of COX, particularly COX-1. It does this by chemically modifying the enzyme. It acetylates a specific serine residue near the active site. This permanently disables that enzyme molecule.
Whereas most other NSAIDs like ibuprofen or naproxen,
They are reversible competitive inhibitors. They bind to the active site and block AA from getting in, but they can also dissociate and the enzyme can become active again. Aspirin's effect is permanent for the life of that specific enzyme molecule.
And a crucial point about all NSAIDs, they block COX but not LOX. What's the consequence of that?
This leads to the shunting effect. If you block the COX pathway, the arachidonic acid that would have gone down that route is now available to be funneled into the still open LOX pathway.
So you might actually increase the production of leukotrienes.
Exactly. By blocking one pathway, you can inadvertently overload the other. This is thought to be the mechanism behind aspirin-induced asthma, which we'll touch on later.
Now, for broader inhibition, we have the glucocorticosteroids, drugs like prednisone or dexamethasone. They hit everything, right? PGs, TXs, LTs. How?
Steroids work further upstream. They don't directly inhibit COX or LOX. Instead, they enter cells, bind to receptors, and alter gene expression. One key thing they do is increase the production of proteins called annexins, also known as lipocortins.
And what do annexins do?
Annexins inhibit phospholipase A2.
Ah, they block the very first step, the release of arachidonic acid from the membrane.
Precisely. By preventing AA release, they cut off the supply of raw material for both the COX and LOX pathways. That's why they have such broad anti-inflammatory effects. They shut down the entire eicosanoid and leukotriene production line at the source.
A much wider net than NSAIDs.
Much wider. Steroids also have another effect. They inhibit the induction of COX-2 synthesis that normally happens during inflammation, so they block the production of the enzyme itself, as well as blocking the release of its substrate. It's a powerful, multi-pronged attack.
And finally, how long do these signals stick around? Are they long-lasting?
Not at all. They are incredibly short-lived. Their plasma half-lives are measured in seconds to minutes. They are rapidly metabolized, especially as they pass through the lungs, into inactive products that are then excreted in the urine. This rapid inactivation is key to their role as local transient mediators.
Okay, we've seen how they're made and inhibited. Now let's get into what they actually do. The range of actions is just staggering. Let's start with the cardiovascular system. It seems like a constant balancing act there.
It really is. Generally speaking, in the CV system, the main prostaglandins are vasodilators. PGE2 causes vasodilation, but the most potent vasodilator among them is PGI2, prostacyclin. Injecting these causes blood vessels to relax and widen, leading to a fall in blood pressure.
And what's pushing the other way, causing constriction?
The main vasoconstrictor is TXA2, thromboxane A2. It consistently causes blood vessels to narrow. PGF2 also tends to be a vasoconstrictor, particularly in larger veins.
But you said they're degraded really quickly, so are they regulating overall blood pressure all the time?
Not really systemic blood pressure in a global sense. Because they're broken down so fast, their main role is as local regulators of vascular tone within a specific tissue or organ bed. PGI2, produced by the endothelium, is constantly fine-tuning blood flow right there in that vessel wall.
That local action is absolutely critical when we talk about platelets and clotting. This is the textbook example of eicosanoid balance, isn't it? The clotting tug-of-war.
It's the perfect example. On one side, you have the platelets themselves. Using their COX-1 enzyme, they produce TXA2. And TXA2 is a powerful activator of platelets. It makes them aggregate, stick together, and release their contents, forming that initial plug when a vessel is injured.
The pro-clotting signal. And on the other side of the rope.
The endothelial cells lining the blood vessel are producing PGI2. And PGI2 is the most potent inhibitor of platelet aggregation known. It keeps platelets calm, prevents them from sticking to the vessel wall or each other when there's no injury, ensuring blood flows smoothly.
So TXA2 says clot, PGI2 says don't clot. It's this constant, localized, antagonistic push-pull.
Exactly. Maintaining the integrity of the circulation, but ready to initiate thrombosis instantly if the vessel wall is breached.
And this brings us back to aspirin's magic in preventing heart attacks and strokes. We need to really understand the selectivity of low-dose aspirin. How does it knock out the platelets' clotting ability without completely wrecking the protective PGI2 from the vessel wall?
It hinges on two things: aspirin's irreversible action and the biology of the platelet. Remember, aspirin acetylates COX-1, permanently disabling it.
Right.
Now, platelets are unique. They're basically cell fragments. They have no nucleus.
Meaning they can't make new proteins?
Exactly. Once aspirin has knocked out the COX-1 enzyme in a platelet, that platelet cannot synthesize any more TXA2 for its entire lifespan, which is about 7 to 10 days. It's permanently silenced from a TXA2 perspective.
But the endothelial cells lining the blood vessel do have nuclei.
Correct. So even though aspirin inhibits their COX enzymes too, these nucleated cells can simply synthesize new COX enzyme molecules relatively quickly, within hours to a day or so. They recover their ability to produce PGI2.
Ah, I see. So by giving a low dose of aspirin regularly, you cumulatively wipe out TXA2 production in the circulating platelet pool because they can't recover.
While the endothelial cells can recover between doses, maintaining at least some protective PGI2 production, it creates this therapeutic window where you shift the balance away from clotting.
That's incredibly clever, exploiting the fundamental biology of the cells involved.
Okay, let's shift to the uterus and reproduction. PGs are major players here, especially in labor. Absolutely central. PGE2 and PGF2 are both powerful contractors of the human uterus, whether pregnant or not. And importantly, the sensitivity of the uterus to these PGs increases dramatically as pregnancy progresses.
So they make the uterus contract, but they also do something else, right, to the cervix.
Yes, a critical dual action. They also cause softening and ripening of the cervix, making it more compliant and ready to dilate. PGs are involved in both initiating and progressing labor. In fact, PGF2 levels rise significantly in amniotic fluid and maternal blood at term.
Which explains why taking aspirin regularly can actually delay the onset of labor and prolong its duration.
Correct, by inhibiting that crucial PG synthesis.
And what about painful periods, dysmenorrhea? Why are NSAIDs often so effective?
Primary dysmenorrhea is strongly associated with an overproduction of PGs, particularly TGF2 and PGE2, in the uterine lining endometrium just before and during menstruation.
And these excess PGs cause?
They cause excessively strong, often uncoordinated uterine contractions. These can be so intense that they restrict blood flow to the uterine muscle, causing ischemia, which leads directly to pain. It's like angina of the uterus.
So NSAIDs work simply by reducing the production of the PGs that are causing the excessive contractions and pain.
Exactly. They target the root cause in many cases of primary dysmenorrhea, which is why they provide such significant relief.
Okay, moving to the lungs. Bronchial muscle and asthma. You mentioned earlier it's a mixed picture here.
Very mixed. You have some eicosanoids that are potent bronchoconstrictors. They make the airways narrow. PGF2s, PGD2, and TXA2 fall into this category. Some are actually more potent constrictors than histamine.
But others do the opposite.
Yes. PGE2 is a powerful bronchodilator. It relaxes airway smooth muscle. PGI2 also causes some mild bronchodilation.
So asthma involves an imbalance, tilted towards the constrictors.
That's thought to be a major component, yes. An imbalance favoring the constrictors like PGs, TXA2, and especially the cystinoid leukotrienes, LTC4 and LTD4, the old SRSA.
Right, the slow-reacting substance.
Over the dilators like PGE2 and PGI2.
This brings us back to the aspirin paradox in asthma. Why does aspirin trigger attacks in some susceptible people? Let's clarify that mechanism again.
Right. In a small subset of individuals with asthma, taking aspirin or other non-selective NSAIDs blocks the COX pathway. As we discussed, this causes the available arachidonic acid to be shunted over to the LOX pathway,
leading to an overproduction of leukotrienes.
Exactly. A sudden surge in the synthesis of LTC4 and LTD4, which are extremely potent bronchoconstrictors, and also increase mucus secretion and airway inflammation. This surge precipitates a severe asthma attack in these sensitive individuals.
And importantly, this reaction generally doesn't happen with selective COX-2 inhibitors.
Correct. Because selective COX-2 inhibitors leave COX-1 relatively untouched, there's less dramatic shunting of AA to the LOX pathway. This suggests the PGs made by COX-1 might normally play some kind of protective role in these individuals, or that the sheer volume of shunting is less.
Fascinating. Okay, let's turn to the gastrointestinal tract. Here, the role of PGs seems mainly protective, mediated by COX-1. What are the key protective actions?
There are really three main ways PGs, especially PGE2 and PGI2 derived from COX-1, protect the stomach lining. First, they reduce acid secretion. They suppress the release of gastrin and directly inhibit the acid-producing parietal cells, decreasing the volume and acidity of gastric juice.
Okay, less acid. What else?
Second, they stimulate the secretion of protective mucus and bicarbonate, HCO3, from the epithelial cells. This creates a viscous alkaline barrier that physically shields the stomach lining from acid and pepsin.
Acid reduction, mucus bicarbonate barrier, and the third.
Third, they help maintain healthy mucosal blood flow. Good blood flow is essential for delivering oxygen and nutrients, removing waste products, and supporting rapid repair if damage occurs.
So PGs are like the stomach's natural defense system, which means that the major side effect of traditional NSAID stomach ulcers is caused precisely by inhibiting COX-1 and stripping away this protection.
Exactly. NSAID-induced ulcerogenesis is a direct consequence of losing these protective PG functions.
And what about the selective COX-2 inhibitors? They were supposed to avoid this by sparing COX-1, did they?
They are definitely less ulcerogenic than traditional NSAIDs. However, it turned out not to be a complete solution. We discovered that COX-2 actually plays a role in healing existing ulcers. It gets induced at the site of injury as part of the repair process.
So while COX-2 inhibitors might be less likely to cause an initial ulcer, they might actually delay the healing of one if it does form.
That's the concern, yes. They can impair the natural healing mechanisms. It highlights that COX-2 isn't always bad.
And quickly, there's also a link between aspirin and colon cancer.
Yes, there's quite strong epidemiological evidence showing that regular long-term use of aspirin is associated with a lower incidence of colorectal cancer and precancerous polyps. The exact mechanism isn't fully clear, but it suggests PGs might be involved in regulating abnormal cell growth in the colon, potentially via COX-2, which is often overexpressed in these cancers.
Let's move to the kidney. PGs seem to act as local regulators here too.
Very much so. Inside the kidney, PGE2 and PGI2 generally promote vasodilation, helping to maintain renal blood flow, especially under conditions of stress. They also promote natriuresis, the excretion of sodium and potassium, essentially helping the kidney get rid of salt and water.
So they help maintain flow and push out salt. What else?
PGE2 can also inhibit chloride reabsorption in certain parts of the tubule and can blunt the effect of antidiuretic hormone, ADH, both of which contribute to a diuretic effect. On the flip side, TXA2 acts locally as a vasoconstrictor in the kidney.
And which COX isoform is mainly responsible for these renal PGs?
It appears that a significant portion of the physiologically important renal PGs, particularly those involved in regulating blood flow and salt handling, are actually products of COX-2, even in the normal kidney. This is one of the early clues that COX-2 had constitutive roles.
Which explains why all NSAIDs, including the selective TOX2 inhibitors, can cause problems like salt and water retention.
Exactly. By inhibiting these vasodilatory natriuretic PGs, whether from COX-1 or COX-2, NSAIDs can lead to reduced renal blood flow, sodium retention edema, and can counteract the effects of diuretics and some blood pressure medications. This is a particular risk in patients with underlying kidney disease, heart failure, or volume depletion.
And PGs also influence renin release.
Yes. PGs, likely acting locally within the kidney, seem to facilitate the release of renin, the enzyme that kicks off the renin-angiotensin-aldosterone system, in response to stimuli like low salt intake or low blood pressure.
Okay, finally for actions, let's talk nerves and pain. PGs don't cause pain directly, do they? They're more like amplifiers.
That's the perfect way to put it. They're powerful sensitizers. PGs, especially PGE2 and PGI2, don't typically activate pain receptors, nociceptors on their own, but they dramatically lower the threshold at which these nerve endings will fire in response to other stimuli.
What kind of stimuli?
Chemical stimuli like brainin or histamine, which are released during inflammation, or even mechanical stimuli. PGs make the nerve endings hyperexcitable, much more sensitive.
So, in an inflamed area, the PGs released there make everything feel tender and sore. They amplify the pain caused by other mediators.
Precisely. They are considered analgesic agents, pain-enhancing agents. This sensitization is a major reason why inflammation is painful. And consequently, inhibiting PG synthesis with drugs like aspirin is a cornerstone of their analgesic pain-relieving effect.
Does this sensitization happen only at the site of injury?
Primarily there, at the peripheral nerve endings. But there's also evidence that PGs can contribute to pain sensitization within the central nervous system, specifically in the spinal cord, further amplifying the pain signals going to the brain.
And their most well-known CNS effect, fever?
Yes, PGE2 is strongly pyrogenic fever-inducing. When your body detects pathogens or tissue damage, immune cells release signaling molecules called pyrogens, mainly cytokines like interleukin-1.
And these pyrogens signal the brain.
They travel to the hypothalamus, the brain's thermostat region. There, they trigger the local synthesis and release of PGE2.
And PGE2 then.
PGE2 acts on neurons in the hypothalamus to effectively reset the body's thermostat to a higher temperature. The body then initiates mechanisms like shivering and vasoconstriction to raise its temperature to this new, higher set point, resulting in fever.
Which COX isoform is key here.
Evidence strongly points to COX-2 being the major isoenzyme responsible for producing this fever-inducing PGE2 in the hypothalamus in response to pyrogens.
Which explains why all effective antipyretics, aspirin, ibuprofen, naproxen, paracetamol, and the selective COX-2 inhibitors work. They all inhibit the production of that critical hypothalamic PGE2.
Exactly. They block the signal that tells the thermostat to turn up the heat.
We've seen this incredible diversity of actions. To understand how one molecule like PGE2 can cause vasodilation in one place and maybe contraction elsewhere, we need to look at the receptors.
Absolutely. The specificity comes from the receptors. All the prostanoids, PGs, TXA2, PGI2, act by binding to specific G protein-coupled receptors, GPCRs, located on the surface of target cells.
And there are distinct families of these receptors.
Yes, 5 main families, each named for the primary prostanoid ligand that binds to it with the highest affinity. DP receptors bind PGD2, EP receptors bind PGE2, FP receptors bind PGF2, IP receptors bind PGA2, prostacyclin, and TP receptors bind TXA2, thromboxane.
So the specific prostanoid made by a cell seeks out its matching receptor on nearby cells, and the type of receptor determines the downstream effect.
Precisely. The magic lies in what happens after the prostanoid binds. These GPCRs are linked intracellularly to different types of G proteins, which then trigger different signaling cascades. We can functionally group these receptors based on the G protein they primarily couple with.
Okay, let's bring that down. Group 1.
The contractile or excitatory group. This includes the EP1 subtype for PGE2, the FP receptor for PGF2, and the TP receptor for TXA2. These receptors predominantly couple to GQ proteins.
And GQ activation leads to?
GQ activates an enzyme called phospholipase C-beta, PLCA. PLC then cleaves a membrane lipid, PIP2, to generate 2 important second messengers, IP3, inositol triphosphate, and DAG, diacylglycerol.
IP3's main job is releasing calcium.
Yes. IP3 triggers the release of calcium ions, Ca2+, from intracellular stores, like the endoplasmic reticulum. This sharp rise in intracellular Ca2+ is the key signal that drives excitatory responses, like smooth muscle contraction. Think uterus contracting via FP receptors, or platelet aggregation via TP receptors.
Okay, so GQ, HB, IPLC, HP, IP3DD, AG, SUM-XN contraction activation, that's the first group. What's the second?
The relaxing group. This includes the DP1 receptor for PGD2, the EP2 and EP4 subtypes for PGE2, and the IP receptor for PTA2. These receptors couple to G's proteins.
G is S for stimulatory. What does it stimulate?
It stimulates the enzyme adenyl cyclase. Adenyl cyclase then converts ATP into cyclic AMP. CMMP, another crucial second messenger.
So G-syn adenyl cyclase increased CMP. And what does high CMP do?
Increased CMP generally leads to inhibitory or relaxant effects in many cell types, often by activating protein kinase A, PKA. For example, in smooth muscle, high CMP leads to relaxation, like PGI2 causing vasodilation via IP receptors. In platelets, high KMP strongly inhibits aggregation, again, the IP receptor effect.
So completely opposite outcomes depending on whether the receptor links to GQ or Gs. Wow. Is there a third group?
Yes, a smaller but important one. The inhibitory group, which mainly consists of the EQ3 subtype receptor for PGE2. This receptor couples to G proteins.
G for inhibitory. What does it inhibit?
It inhibits adenyl cyclase. So activation of D leads to a decrease in intracellular CMP levels.
Okay, so G inhibits adenyl cyclase, decreased KMP. What kind of effects does that cause?
The EP3 receptor is widely distributed. Its G coupling is responsible for some of PGE2's inhibitory actions, like its antilipolytic effect inhibiting the breakdown of fat in adipose tissue. It can also mediate smooth muscle contraction in some tissues, showing that the KMP pathway isn't the only determinant of relaxation contraction.
It's complex. Let's revisit the EP receptors quickly, since PGE2 binds to 4 different subtypes: EP1, EP2, EP3, EP4, explaining its incredibly diverse actions.
Exactly. EP1 is contractile. GQ increases Ca2+, found often in visceral smooth muscle. EP2 and EP4 are both relaxant. G's increase KMP. EP4 is very widely distributed and seems involved in longer-term effects like hormone release. And EP3 is the inhibitory one. G decreases KMP, important for that antilipolytic effect and other actions.
And we have to reemphasize the TP and IP receptors, the core of the clotting balance.
Absolutely. TP receptors, primarily on platelets and vascular smooth muscle, bind TXA2, coupled to GQ and maybe G16, activate PLCG, increase calcium, and drive aggregation and contraction.
While IP receptors, abundant on platelets in the vasculature, bind PGI2, coupled to Gs, activate adenyl cyclase, increase KMP, and powerfully inhibit aggregation and cause relaxation.
The cell type expressing the receptor and the specific G protein coupling dictates the outcome. It's beautifully regulated.
Now, what about the leukotriene receptors? Do they follow similar principles?
They do. They're also GPCRs. There are 2 main classes: BLT receptors for LTB4 and C-stenol LT, cisel LT receptors for LTC4, LTD4, and LTE4.
And their signaling mechanism?
All the major LT receptors predominantly couple through GQ proteins. So like the TP and FP receptors, they signal via the PLC IP3D-DDK2 plus release pathway. This generally leads to excitatory responses like contraction or cell activation.
Let's look at the specifics, the BLT receptors.
There are two subtypes, BLT1, high affinity for LTB4, and BLT2, lower affinity. They're primarily expressed on leukocytes, neutrophils, monocytes, macrophages, T cells, and also in the spleen.
And LTB4 binding to these causes.
LTB4 is an incredibly potent chemotactic agent. Binding to BLT receptors draws these inflammatory cells towards the site of inflammation. It's a major signal saying immune cells come here.
Okay, and the cysteinyl LT receptors, CysLT, these are the targets for asthma drugs.
Correct. There are two main subtypes here as well, CysLT1 and CysLT2.
CysLT1, where is it found and what does it do?
CysLT1 receptors are found mainly on smooth muscle cells, particularly in the bronchioles and also in the intestines, as well as on certain immune cells like the eosinophils and mast cells. They have a somewhat higher affinity for LTD4 than LTC4.
And this is the receptor blocked by drugs like montelukast.
Exactly. Montelukast singulaire and zafirlukast acolyte are selective CysLT1 receptor antagonists. By blocking LTD4 and LTC4 from binding here, they prevent the potent, sustained bronchoconstriction, mucus secretion, and airway edema that characterize asthma. That's why they're valuable asthma therapies.
What about CysLT2?
CysLT2 receptors are also found on immune cells, mast cells, eosinophils, macrophages, and in tissues like the spleen and peripheral blood vessels. They seem to bind LTC4 and LTD4 with roughly equal affinity. Their precise role is less well understood than CysLT1, but they likely contribute to inflammatory responses as well.
Okay, we've covered the eicosanoids in detail. Now let's turn to their equally powerful, though chemically distinct cousin, platelet activating factor, PAF.
Right. PAF is not derived from arachidonic acid in the same way. It's an acetylglycerol ether phosphorylcholine. Basically, it's a unique type of phospholipid, a polar lipid derived from cell membranes.
And its defining feature?
It's absolutely incredible potency. PAF is biologically active at extremely low concentrations, down in the subnanomolar range. It's one of the most potent endogenous signaling molecules known.
Like the eicosanoids, is it stored or made on demand?
Strictly on demand. Synthesized from precursor phospholipids already present in the cell membrane when the cell is stimulated. There are no preformed stores. The second step in its synthesis pathway is typically the rate-limiting one.
And which cells make PAF? Is it widespread?
The synthesis is somewhat more restricted than for eicosanoids. The main producers are inflammatory cells, neutrophils, eosinophils, monocytes, macrophages, platelets themselves, vascular endothelial cells, and also some kidney cells.
Let's look at its actions. The name says platelet activating factor.
And it certainly does that. PAF is a very potent inducer of platelet aggregation and the release reaction. Interestingly, it also stimulates platelets to release their own mediators, including TXA2, amplifying the clotting response. Injecting PAF intravenously can cause widespread intravascular thrombosis.
What about its effects on other white blood cells?
It's a powerful chemotactic agent for neutrophils, eosinophils, and monocytes, drawing them to sites of inflammation, much like LTB4. It also stimulates these cells to aggregate, stick to the endothelium, and release their contents, like lysosomal enzymes and even more LTs. It really ramps up the inflammatory cascade.
And its effects on blood vessels?
PAF is famous for being the most potent substance known to increase vascular permeability. It makes capillaries leaky, causing fluid and proteins to leak out into the tissues, leading to rapid local swelling and edema, a cardinal sign of inflammation.
Does it affect blood pressure?
Yes. If injected systemically, it causes a profound fall in blood pressure. This is partly due to widespread vasodilation, possibly mediated by release of nitric oxide, EDRF, but also complicated by platelet aggregation, potentially clogging small vessels. Paradoxically, while causing systemic vasodilation, it can decrease coronary blood flow, likely due to platelet aggregates and TXA2 release in the heart's vessels.
What about smooth muscle outside the vasculature, like in the airways?
PAF is a potent bronchoconstrictor. Inhaling PAF causes immediate airway narrowing. But perhaps more significantly, it also causes mucosal edema, increased mucus secretion, and uniquely a prolonged bronchial hyperresponsiveness.
What does that mean, hyperresponsiveness?
It means that after exposure to PAF, the airways remain twitchy and hypersensitive to other stimuli for a long time, hours or even days. This long-lasting hyperreactivity is a key feature of chronic asthma, and PAF is strongly implicated in contributing to it.
So LTs cause the acute attack. PAF might contribute to the underlying chronic sensitivity.
That's one way to think about it, yes. PAF also stimulates smooth muscle in the intestines and the uterus.
And its effect on the stomach. We heard PGs are protective, but PAF.
PAF is the opposite. It's highly ulcerogenic. Intravenous PAF causes gastric erosions and bleeding very rapidly. It's a powerful damaging agent to the gastric mucosa.
How does PAF exert all these effects? Does it have its own receptor?
Yes, it acts via a specific PAF receptor, which is also a membrane-bound GPCR. It primarily couples through GQ, activating the PLC-IP3DAG-K2+ pathway, similar to TP, FP, and LT receptors. It can also sometimes couple to G to inhibit adenyl cyclase.
And do its actions stand alone, or does it work with the eicosanoids?
There's significant synergy. Many of PAF's effects, especially in inflammation and thrombosis, are either mediated by or strongly augmented by the subsequent release of PGs, TXA2, and LTs from the cells that PAF activates. PAF triggers the release of these other mediators, creating a positive feedback loop and amplifying the response.
So PAF acts as both a primary signal and a trigger for secondary signals.
Exactly. It also seems to have some direct intracellular actions, for example, rapidly exposing fibrinogen binding sites on neutrophils.
Given its role in so many nasty processes, inflammation, asthma, shock, thrombosis, ulcers, you'd think PAF antagonists would be major drugs.
Logically, yes. PAF is implicated in all those conditions. And antagonists have been developed and investigated. Compounds like ginkgolide B from the ginkgo biloba tree were studied. The potential therapeutic applications seemed enormous: stroke, sepsis, asthma, ulcers, transplant rejection.
But none are currently marketed. Why not?
It's proven very difficult. PAF is such a fundamental, potent, and widespread mediator involved in so many processes that blocking it systemically might have unforeseen or unacceptable side effects. Also, its effects are often very rapid and localized, making it hard to intervene effectively with the drug. So despite the theoretical promise, translating PAF antagonism into safe and effective clinical therapies has been a major challenge.
Okay, so we've seen the complex physiology and pathology. Let's talk about how we actually use these molecules or drugs that target them in the clinic. You mentioned the endogenous PGs themselves have limitations?
They do. Their very short half-lives mean they often need to be given by continuous infusion, which is inconvenient. They can be expensive to produce. And because they have such widespread actions, systemic administration often causes significant side effects. However, in specific situations, particularly where local effects are desired, they, or more often their stable synthetic analogues, are invaluable.
Let's start with obstetrics and gynecology. This seems to be a major area for PG use.
Absolutely. They're used extensively for several purposes. One is abortion or medical termination of pregnancy.
How are they used there?
Often for cervical priming. Before a surgical evacuation, especially in the first trimester, a PGE2 analog pessary might be inserted into the vagina. This softens and ripens the cervix, making dilation easier and reducing the risk of trauma.
And for non-surgical termination.
The standard medical abortion regimen, highly effective especially up to 9-10 weeks, combines mifepristone, an antiprogestin that makes the uterus sensitive to PGs, followed a day or two later by a PG analog, most commonly misoprostol.
Misoprostol, that's a stable PGE1 analog, right? Not PGE2? Why PGE1?
Yes, misoprostol is a synthetic analog of PGE1. Analogs like misoprostol are often preferred because they are chemically more stable, have a longer duration of action than natural PGE2, and can be given orally or vaginally, making them more practical for clinical use. Is very effective at causing the uterine contractions needed to expel the pregnancy.
Are PGs used for later-term abortions too?
Yes, particularly for mid-trimester terminations or in cases of molar gestation. In these situations, the uterus is often resistant to oxytocin, the standard drug used to induce contractions later in pregnancy. PGs can effectively convert the uterus from an oxytocin-resistant state to an oxytocin-responsive one, or induce abortion on their own.
What about inducing labor at term?
PGE2 is widely used for labor induction or augmentation, particularly when the cervix is unfavorable, unripe. It can be given as a vaginal gel or pessary. It's sometimes preferred over oxytocin in patients with conditions like preeclampsia, toxemia, or renal failure, because high doses of oxytocin can cause water retention, which is undesirable in these patients.
And that cervical ripening effect is used on its own, too.
Yes, cervical priming or ripening is a key application. Low doses of PGE2, like the product Cerviprime, can be applied locally to the cervix. This softens and effaces the cervix, making it more favorable for subsequent induction with oxytocin, increasing the success rate and potentially shortening labor. It does this without necessarily causing strong uterine contractions itself at these low doses.
And what about emergencies after birth, like postpartum hemorrhage, PPH?
If PPH occurs due to uterine atony, the uterus failing to contract down properly after delivery, and it doesn't respond to standard drugs like oxytocin or ergometrin, then a potent, long-acting PG analog is often the next step. The drug used here is carboprost.
Carboprost is.
It's 15-methyl-PGF2. It's an analog of PGF2, a potent uterine contractor. The addition of the methyl group at position 15 makes it resistant to metabolic breakdown, giving it a much longer duration of action. It's given by intramuscular injection and can cause powerful uterine contractions to stop the bleeding. It's a life-saving drug in this situation, although it can have significant side effects like nausea, vomiting, diarrhea, and sometimes bronchospasm.
Okay, moving away from obstetrics, what about cardiovascular and pulmonary uses? You mentioned keeping the ductus arteriosus open.
Yes, a critical use in neonatology. In babies born with certain congenital heart defects, like transposition of the great arteries or severe pulmonary stenosis, their survival depends on blood flowing through the ductus arteriosus, a vessel connecting the pulmonary artery and aorta that normally closes shortly after birth.
So you need to keep it open until surgery.
Exactly. A continuous intravenous infusion of PGE1, alprostadil, is used to maintain the patency of the ductus arteriosus, providing a vital lifeline for these infants until corrective surgery can be performed.
And what about managing platelets during procedures like dialysis?
When blood has to circulate outside the body, like during hemodialysis or cardiopulmonary bypass surgery, there's a high risk of platelets becoming activated and forming clots in the extracorporeal circuit.
So you need an anticoagulant.
You use systemic anticoagulants like heparin, but you can also specifically target platelet activation using PGI2, prostanoid. It's infused into the circuit to prevent platelet aggregation and damage. Because it's so rapidly metabolized, half-life of minutes, its anti-platelet effect stops almost immediately when the infusion is discontinued, avoiding prolonged bleeding risk after the procedure.
PGI2 is also used for pulmonary hypertension.
Yes, for severe pulmonary arterial hypertension, PAH. A continuous intravenous infusion of PGI2, or more stable analogs like iloprost or treprostinil, which can sometimes be inhaled or given subcutaneously, is a mainstay of therapy. PGI2 is a potent pulmonary vasodilator, helping to lower the dangerously high pressure in the pulmonary arteries.
Are PGs used for blocked arteries elsewhere, like in the legs?
Sometimes. In severe peripheral vascular diseases, PVD, like critical limb ischemia and Raynaud's disease or intermittent claudication, intravenous infusions of PGI2 or PGE1 have been used. They can cause vasodilation, potentially improve blood flow, relieve rest pain, and sometimes help heal ischemic ulcers. However, the benefit is often temporary and use is limited by side effects and the need for infusion.
And perhaps less critical but well-known use.
Yeah.
Impotence.
Yes, direct injection of PGE1, alprostadil, into the penis, intracavernosal injection, causes vasodilation and smooth muscle relaxation leading to an erection. It was a major treatment for erectile dysfunction before effective oral drugs like sildenafil became available. Alprostadil is also available as a urethral suppository, MUSC. While effective, the injection is obviously invasive, and oral drugs are now generally preferred first line.
Let's cover the other key uses. Glaucoma is a big one now for PG analogs.
A huge one. Topical PGF2 analogs, drugs like latanoprost, travoprost, bimatoprost, applied as eye drops, are now typically first-line treatment for open-angle glaucoma.
How do they work? They're FP receptor agonists, right?
Yes, they bind to FP receptors in the eye. Their primary mechanism is to increase the outflow of aqueous humor, the fluid inside the eye, primarily through the unconventional or uvascleral outflow pathway. By improving drainage, they lower the intraocular pressure that damages the optic nerve in glaucoma.
So they don't reduce fluid production, they just open the drains more.
That's the main mechanism, yes. It's very effective. Side effects are usually local, like eye redness, stinging, and famously they can cause darkening of the iris color and increased eyelash growth.
And finally, back to peptic ulcer prevention.
Right. We mentioned the stable PGE1 analog misoprostol. Its main indication is preventing gastric ulcers, specifically in patients who are taking chronic NSAI therapy, especially high-risk patients. For example, elderly history of ulcers. It substitutes for the protective PBs that are lost due to NSAIDs-induced COX-1 inhibition.
But it's not used for routine ulcers.
Generally not for healing routine ulcers unrelated to NSAIDs, mainly because it often causes side effects like diarrhea and abdominal cramps, and other drugs like proton pump inhibitors, PPIs, are usually more effective and better tolerated for standard ulcer treatment. Its niche is really NSAID-induced ulcer prophylaxis.
Okay, so summarizing the side effects across these various PG uses.
It really depends on the specific PG, the dose, and the route of administration. But common ones, especially with systemic use, include nausea, vomiting, watery diarrhea, especially with PGEs, uterine cramps or excessively forceful contractions, PGFs, PGEs, vaginal bleeding, flushing, headache, sometimes fever, and potentially a fall in blood pressure with tachycardia, especially with vasodilators like PGI2, PGE1. Local administration like eye drops or vaginal gels tends to have more localized side effects. #HAG outro broad.
So wrapping this up, what we've really dug into today is how these tiny, incredibly short-lived lipid molecules, the eicosanoids and PAF, function as this hyper-localized, on-demand signaling system. They're like instant messages controlling absolutely critical processes, from the baseline protection of your stomach lining via COX-1.
To the immediate clotting response driven by platelet TXA2, the counterbalancing flow maintained by endothelial PGI2, and the acute, intense bronchoconstriction of an asthma attack driven by leukotrienes like LTC4 and D4.
They really are the command structure for immediate physiological responses.
And the sheer elegance, but also the complexity, lies in that localization and specificity. Think again about TXA2 and PGI2 made by different cells right next to each other, using the same precursor PGH2, but coupling to opposing G protein pathways, GQ versus GS, to execute this instantaneous life or death balance between clotting and flow.
It really highlights why just inhibiting one part of the system, like aspirin irreversibly hitting COX-1, has such profound and widespread consequences.
Exactly. You're not just affecting one isolated pathway, you're potentially altering dozens of these finely tuned local balances throughout the body.
Which brings us to a final provocative thought for you, our listeners, to take away and mull over. We've discussed how NSAIDs can shunt arachidonic acid towards leukotriene production. We also noted that COX-2, while driving inflammation, is actually induced as part of the beneficial process of ulcer healing, and that NSAIDs, even selective ones, can delay that healing.
Right, and we also know that COX-2 has important constitutive physiological roles in places like the kidney and the brain.
So the question is, when people use NSAIDs chronically, whether non-selective or even COX-2 selective ones, what are the potential unseen consequences? Are we inadvertently suppressing necessary, localized, beneficial housekeeping or repair functions of TOX2 in organs beyond the joints like the kidneys or maybe even the brain? What might be the long-term health implications, particularly for renal function or maybe even CNS health, of subtly disrupting these constitutive COX2 pathways day after day, year after year?
It's a complex interplay, and understanding these nuances is key as you continue to build your mastery in this fascinating and critical area of pharmacology and physiology, something definitely worth considering.